Let's get started with our first panel of speakers. We're going to introduce Dr. Jonathan Schwartz, Dr. Juan Bueren, and Dr. Agnieszka Czechowicz. They'll be sharing about their respective gene therapy clinical trials. Thank you so much for being here. Jonathan, the floor is all yours.
Thank you, Jordan. You can hear me okay? Good. It's a pleasure to be here, and we very much appreciate the opportunity to share some of the work and ongoing progress that's occurring with the gene therapy programs in the United States and in Europe. The coming hour will provide a couple of critical updates, both with respect to the Spanish and Stanford phase 1 studies that have taken place over recent years. And then we'll also talk a little bit about the current program. The next slide illustrates the individuals participating, which includes myself, Jonathan Schwartz from Rocket Pharma. I'm a hematologist and oncologist myself and have been developing medicines for very difficult diseases for the better part of the last 20 years. And then we'll also have Dr. Bueren from CIEMAT in Madrid, Spain. Juan Bueren is the director of the Innovative Therapies Division for CIEMAT. And for those of you that are not familiar, CIEMAT is kind of like the NIH of Spain. It's a government subsidiary which has a great deal of scientific expertise and for the most part is a pleasure to work with. Additionally, we'll have Dr. Czechowicz from Stanford. She's an assistant professor of pediatric stem cell transplant in Palo Alto. The next slide illustrates the general topics, and I will begin by providing a bit of introduction to gene therapy in Fanconi anemia, and then we'll also conclude, we'll talk a bit about the clinical trial plans in the United States and in Europe. And I'll get started right away and then introduce Drs. Bueren and Czechowicz as appropriate. Moving to the next slide. At this point, many of you are quite familiar with some of the critical things that make Fanconi anemia. We'll review this briefly and then discuss the potential role of gene therapy. Fanconi anemia is a genetic disorder, and specifically one that requires a patient to inherit genes from both parents, both biological parents, and the disease is characterized by several critical pathophysiologic manifestations, most importantly, some deficits in aspects of DNA repair. All of our cells, all of our tissues are constantly exposed to potential DNA damage, both from environmental stresses, please stand, thank you, both from environmental stresses as well as other more natural factors. And frequently we're able to repair this damage. However, when DNA damage cannot be repaired, this can result in a number of issues, including bone marrow failure, where the bone marrow ceases to produce enough cells to enable the blood to function properly. And it can also result in malignancy formation, cancers of both the blood system and other organs. Moving to the next slide, Fanconi anemia is diagnosed by many different means. Sometimes patients will have congenital abnormalities that may alert clinicians to the fact that something is not right, and sometimes not. Each patient is different, each story is different, and that is extremely true within Fanconi anemia. The diagnosis hinges in 2020 on genetic testing and also on other evaluations, including chromosome fragility tests, where patients' cells are exposed to DNA damaging agents, and the behavior in the face of these DNA damaging agents will at times confirm or enable a Fanconi anemia diagnosis. And this is illustrated a little bit more detail on the next slide. This describes a DEB, chromosomal fragility test. And this is a test that involves a collection of blood from someone, a type of white blood cell, specifically a T lymphocyte, is cultured in a laboratory, a group of these cells, in the presence of a low concentration of chemicals that are harmful to DNA, such as diepoxybutane or DEB. After a week or two, these cells are then looked at under a microscope. In the absence of a disorder like Fanconi anemia, the chromosomes appear more or less normal, as the image on the lower left portion of the slide indicates, where they're all kind of sitting there more or less intact. However, in Fanconi anemia, even the low concentration of an agent like DEB results in breaks in the chromosomes, and sometimes these broken chromosomes form abnormal clusters or radials. Then that's illustrated in the right panel, and that's a result that's indicative of Fanconi anemia. And we mention this in detail because this is one of the mechanisms by which we think we can test effectively whether or not gene therapy might be working in any given patient. And Dr. Bueren and Czechowicz will provide a little bit more information on that in a few moments. The next slide illustrates a phenomenon known as mosaicism, or natural gene therapy. And this is something that occurs relatively rarely. And in this setting, a rare spontaneous second mutation occurs in a blood cell, specifically a blood stem cell, which enables that cell and its progeny to generate a functional Fanconi anemia DNA repair complex. This is a phenomenon known as mosaicism or somatic mosaicism, and these mutations are sometimes called reversion mutations or compensatory mutations. And in selected instances, this type of mutation has allowed the stem cells to grow more consistently and robustly compared to other Fanconi cells. And in some instances, this has been shown to resupply the bone marrow and the blood with a population of healthy behaving and healthy appearing cells. And this has been, this growth advantage is sometimes called a selective advantage, and it's been demonstrated in gene-corrected cells from Fanconi patients when they've been injected into mice. It's also been demonstrated in several dozen patients with these type of mutations, these mosaic patients. And then most recently, this has been demonstrated in some of the patients participating in the initial gene therapy trials. And Dr. Bueren is going to show you some details about that in several minutes. Next slide. Gene therapy is in some respects an attempt to replicate that phenomenon and to put a copy of a correct and functional Fanconi anemia gene into a population of blood stem cells so that those blood stem cells can grow and hopefully enable healthy blood and bone marrow to form. This is done by means of a vector, which is a term for a virus that has been supplied with a copy of the correct gene and disabled, so it can't reproduce or cause infections, but it can put the healthy or normal gene into blood stem cells. There's some types of gene therapy that are delivered directly into patients. That's usually for disorders of nerves and muscles. In the case of blood disorders, this is done with blood cells that are removed from a patient's body and then put back, and that's known as ex vivo gene therapy, which is illustrated on the subsequent slide. Gene therapy in Fanconi anemia involves several critical steps, the first of which is collection of the blood stem cells, and that's done with a process that takes about a week, involving agents that mobilize stem cells from the bone marrow into the peripheral blood. Those agents are given over the course of about a week, and then generally 2 days of a procedure known as apheresis, where blood is removed, some of the cells are isolated, the blood is put back into a patient, and then that stem cell collection from the apheresis is then further worked on in a laboratory. And moving to the right portion of the slide, the stem cells are selected or further purified, and then they're transduced, where they're introduced to the vector that's hopefully inserting the corrected gene. And that takes several days. And then without any freezing or any other activities, those cells are then infused intravenously back into a patient. In some gene therapies, cells are infused with chemotherapy given before the infusion, known as conditioning, which clears out bone marrow. Because Fanconi patients are very sensitive to chemotherapy, and because of the selective advantage of the gene-corrected stem cells that we talked about a couple minutes ago, the current gene therapy trials are not utilizing any conditioning. So the cells are introduced to the vector, the gene is hopefully transduced, and then they're infused back into the patient several days after they've been removed. Next slide, please. This is a slide that's illustrating both the phase 1 and phase 2 studies that have been conducted and are currently being conducted in Fanconi anemia. Phase 1 studies are focused predominantly on safety and a preliminary assessment of efficacy, and phase 2 studies involve an assessment of efficacy as well as safety. Dr. Bueren will talk about the Fanconi 1 study in Madrid, in which 9 patients were treated, and subsequent to that, Dr. Czechowicz will talk about the US phase 1 study, in which 2 patients received therapy in the beginning months of last year, 2019. And then towards the end of the hour, we'll spend some time talking about the phase 2 studies that are underway and or starting up currently, both in Europe and North America. So with that, please let me introduce Professor Bueren. Thank you very much, Juan.
Okay, thank you very much, Jonathan, and thank you to the rest of the organizers for inviting me to attend this gene therapy session in Fanconi anemia. And because this is my first meeting in the FARF family meeting, I have prepared the following slide, in which I have included, may I have next slide, please? In this slide, I have included some of the historic most relevant events of Fanconi anemia at the CIEMAT. As you can see, our first participation in a FARF meeting was in 2000. This was a meeting that took place in Geneva. 1 year afterwards, we organized, in collaboration with other Spanish colleagues, the first meeting on Fanconi anemia, and in fact, this was organized in our institution. And only 2 years afterwards, with efforts of several other colleagues and FA families, we the creation of the Spanish FA Association, which, as many of you know, is extremely active. And here I'm showing a slide of one of the parties that were organized by this association in the small village of Pedraza, where a very famous singer in Spain was invited. So many other activities were performed in years afterwards. And importantly, after having obtained some grants for the funding of FA gene therapy trials, it was in 2016 when we infused the first FA patient. And even though things were going very nicely, it was by the end of 2016 when funding from both national and European grants were almost finished. And by that time, we had the possibility of contacting with colleagues from Rocket Pharma. In particular, we met with Gaurav Shah, the current CEO of the company. And thanks to all these meetings, it was by the end of 2016 that it was possible to have this agreement for the development of a long-term study of gene therapy, not only in Spain, but also all around the world. And nowadays, we are developing gene therapy trials that are under the sponsorship of Rocket Pharma. So on next slide, what I'm showing is the study that I will present today, which are the results of the first 9 patients that have been treated in the phase 1 gene therapy trial here in Madrid. Next slide. Well, of course, the aim of a first gene therapy trial is safety. So this was the main objective of our trial. And also we aim to develop preliminary evidence of efficacy in gene therapy treated patients. As I mentioned, we enrolled 9 patients aging between 3 and 7 years. And all these patients showed decreasing peripheral blood cell counts before treatment by gene therapy. And as Dr. Shaw mentioned, none of these patients received any chemo or radiotherapy before the conditioning based on our preclinical studies and also what we learned from mosaic patients showing that gene-corrected stem cells from FA patients develop a growth proliferation advantage as compared to uncorrected cells. Okay, next slide. So what we expect from gene therapy treated patients? Well, the question is that after gene correction of the stem cells, the hope is that after infusion in peripheral blood, gene-corrected stem cells will be able to home in the bone marrow niches, and in those regions, they will progressively proliferate and generate additional bone marrow cells, which thereafter will generate gene-corrected peripheral blood cells in the bloodstream. Okay, next slide. Well, what are the main goals that we should achieve in the gene therapy trial? And the first thing we should be able to demonstrate is engraftment. Engraftment of gene-corrected stem cells in the patients. And first of all, what we need to be able to demonstrate is the presence, the progressive increase of bone marrow stem cells containing the corrected version of the Fanconi gene that is damaged in the patients. And in this first trial, we focused on patients with the FAA complementation group. So the first question was, do cells from these patients in bone marrow show the presence of the correct Fanconi anemia A gene, which is present in the therapeutic lentiviral vector? The second point was to demonstrate function. Do the bone marrow cells from the patient have an improved function as compared to uncorrected cells? And as it was mentioned by Jonathan, one of the best ways to demonstrate improved function in FA cells is to demonstrate that these cells, which normally are highly sensitive to drugs that generate DNA damage, these cells in turn should become resistant to this type of drugs. And similarly, in peripheral blood, the characteristic chromosomal aberrations observed in peripheral blood lymphocytes should be reverted as a consequence of the genotypic correction due to the insertion of the correct Fanconi anemia gene. And finally, if everything works as expected, this should have an implication in the stabilization of the bone marrow failure of the patients. So let's take a look of what happened in the 7 patients that had significant follow-up of at least 1 year until the 3rd year of follow-up, which means the end of the clinical trial. So what this slide firstly shows is related to engraftment. Engraftment of gene-corrected cells in peripheral blood. You can see how the proportion of peripheral blood cells with the corrected version of the Fanconi anemia A gene progressively increases in most of the treated patients, in all of them except in one of the patients, 2007, in which the number of stem cells that could be collected and therefore infused in this patient was extremely low. So despite the total number of corrected stem cells that were infused in these FA patients was significantly lower if we do a comparison with other clinical trials with different diseases. And despite the fact that none of these patients received any chemotherapy nor radiotherapy, in all these patients, progressive increases of gene-marked cells were observed. And even in the first patient that you can see, 60% of cells in peripheral blood are gene-marked cells containing the corrected Fanconi anemia A gene. On next slide, you can see something very similar. I'm not going to enter into details, but this slide is very similar to the previous one and only aims to demonstrate that the gene marking in peripheral blood cells is not specific to some type of lymphoid, myeloid, or red blood cells or platelets. All the cells that we have tested are gene marked. So this was one of our evidences demonstrating that we are genetically correcting pluripotent stem cells in these patients. In next slide, now we move from engraftment to improved function in the stem cells of the patients. And in the 4 patients with the longest follow-up, this was clearly shown. What we are showing in the slide is that while before doing gene therapy, all the progenitor cells, or on the other way, none of the progenitor cells of the patients could survive to a genotoxic drug such as mitomycin C, progressively after infusion of gene-corrected cells, we observed that as with gene marking, all these progenitor cells became resistant to this genotoxic drug. This is bone marrow, and if we take a look to peripheral blood, we can see, next slide please, we can see, first of all, in this case what is represented is the proportion of peripheral blood lymphocytes with chromosomal breaks. So, first of all, you can see that in standard FA patients, most, about 80% of peripheral blood lymphocytes contain chromosomal breaks when these cells are challenged with another genotoxic drug, the epoxybutane. And also you can see how, in contrast to the situation that was observed before gene therapy, progressively after gene therapy, the proportion of lymphocytes with chromosomal breaks decreases. Once again, demonstrating that the function of those peripheral blood cells is restored. Okay, and what happens with respect to numbers? Total numbers of peripheral blood cells. And what this slide represents is the number of uncorrected leukocytes in the different patients that have been treated by gene therapy. So in red dots, what you can see is the progression of uncorrected leukocytes before or after gene therapy. So as expected, the total number of uncorrected leukocytes is not modified at all by gene therapy. But in high contrast to the kinetics of these uncorrected leukocytes, marked increases in the total number of corrected leukocytes is observed after infusion of gene therapy stem cells, gene-corrected stem cells. And in fact, in one of the patients, the total number of corrected leukocytes nowadays is higher as compared to total number of uncorrected leukocytes. If we take a look at total number in all the different lineages, in next slide, what we can see is the following. In red is represented total number of platelets prior to and after gene therapy, in blue neutrophils, and in red hemoglobin values. And interestingly, in the first two patients, which were the ones with higher levels of engraftment, what we can see is that despite the fast decrease in peripheral blood cells before gene therapy, after gene therapy, there is stabilization in platelets and in neutrophils. And if we take a look at hemoglobin values, even we see progressive increases in these values after gene therapy. So taken together, what we can conclude on next slide from the patients that have been treated so far is that gene therapy appears to be safe. Now we also have preliminary evidence of efficacy in these patients without any conditioning treatment. And in these patients, we can conclude that there are increasing numbers of gene-corrected cells in bone marrow and in peripheral blood, which is associated with increased resistance to DNA damaging agents in both tissues, and also with stabilization or even with evidence of increased hemoglobin levels in patients treated with higher numbers of gene-corrected stem cells. Next slide, please. So now, by the hand of our Rocket Pharma, we have started the phase 2 gene therapy trial, both in Spain and in London, and a total number of 5 patients will be treated here in Europe. Next slide. What we plan to do is now to treat patients in earlier stages of the bone marrow failure, once that we are seeing that this treatment is safe. And also we plan to infuse higher numbers of gene-corrected stem cells, in part due to the collection of the stem cells in earlier stages of the bone marrow failure. And the patients, as we have done in the phase 1 trial, will be infused in Spain in Hospital del Niño Jesús and at the UCL GOS in London in the UK. Next slide. So last, but of course not least, I would like to thank the colleagues that have been more actively participating in this clinical trial. At the CIEMAT, of course, Paula Rio and also Susana Navarro, who are key people in this trial. Julián Sevilla is the PI of the gene therapy trial at Hospital del Niño Jesús, and Cristina Díaz de Heredia of the mobilization trial. There are also key and important people at the CIEMAT, many of them working at the GMP facility for the genetic manipulation of the cells. I would also wish to thank many colleagues of the European program, Eurofancolen, and of course all our colleagues from Rocket Pharma. Thanks to them, we can envisage that gene therapy in the future will be a real treatment for patients with FA. And very finally, also I want to thank, on next slide, to the Fanconi Anemia Foundation in Spain, whose collaboration, both the physicians, patients, families, are essential for the initiation and the continuation of these gene therapy trials. And of course, the person that is taking care of the family support of our patients in Spain, Aurora de la Cal. Thank you very much. And Jonathan, if you would like to continue with the session, you are welcome.
Okay, gracias, Juan. And we will continue now. Dr. Czechowicz from Stanford will provide an overview of the phase 1 study that enrolled patients last year in California. These patients continue to be under her follow-up. Thank you, Agnieszka.
Thank you, everyone, for the opportunity to speak today and tell you about our gene therapy program here at Stanford, which of course would not be possible had it not been for the efforts of our colleagues at Rocket Pharma, and most definitely the efforts of our colleagues in Spain who have been working on this program for now many, many years. So today I'd like to tell you about our phase 1 study that we opened earlier last year, and where we treated 2 patients with Fanconi anemia type A. Next slide. So again, this is an ongoing update of our trials here at Stanford Children's Hospital. Next slide. So the phase 1 trial that we ran last year is known as the number above, RPL 102-0418. And this was a phase 1 study to test the same type of gene therapy that Jonathan and Juan spoke about earlier. Again, because this was a phase 1 study, the goal was really to look at safety of the gene therapy in these FA patients. The study enrolled 2 patients who had Fanconi anemia type A, or between the ages of 1 and 12, and who had started to show some signs of decreasing blood counts, which is a requirement of the phase 1 study. Patients were excluded from the trial if they had an HLA identical sibling, if they had MDS or leukemia, or if they had mosaicism. Next slide. Again, the treatment was, as Jonathan and Juan mentioned, we followed the exact same protocol with the same mobilization medicines to cause the stem cells to leave the bone marrow and go into the blood. Then we apheresed them to remove them from the blood. Then the stem cells were purified. And then in a commercial manufacturing facility nearby, the Fanconi gene was reinserted into those stem cells, and then they were infused immediately fresh back into our patients here at Stanford. Next slide. Again, as I mentioned, this was a phase 1 study that had 2 patients. We were able to enroll patients rather quickly and treat them without concern. And these are the characteristics of the two patients that we treated, both young girls, a 5-year-old and a 6-year-old, who again had started to have decreased blood counts. The first patient had slightly more normal blood counts, and the second patient had more severe signs of bone marrow failure, where the hemoglobin of the first patient was 11.9 and the second patient was 8.9, and the platelet count in the first patient was 55,000 and in the second patient was 38,000. Again, we were able to mobilize the stem cells and create the gene therapy product without concern. And on the lower part of this slide is the actual gene therapy product that was later infused into the patients. And what you can see here is that in both patients, we were able to collect a good number of stem cells, purify those stem cells from that product, and then the gene was reinserted well, showing a good amount of vector copy number in that gene therapy product. And then importantly, when that product was tested for its ability to survive that DNA damaging agent, which we know that Fanconi anemia patients can't do without the gene therapy, we saw very good survival of those cells. Next slide. Again, the goal of this phase 1 study was to look at safety, and we saw very good safety associated with this treatment. There were no adverse events related to the administration of these gene-modified cells. And we only saw typical issues associated with pediatric patients. One patient developed some fever and some croup, not associated with the gene therapy, but later in treatment. I must note that during the treatment itself, we did do extensive monitoring of these patients, and we did see some mild changes in their electrolytes, which were corrected, and both patients also experienced a mild anemia and thrombocytopenia during the actual collection of the stem cells, and did receive portions of transfusion products in order to keep those cells a bit higher. But after treatment, they did not immediately need transfusions. Next slide. This figure illustrates the blood counts of these first two patients over the first 6 months that showed a general stabilization of the blood counts over this period of time. And it's really this data that then allowed us to proceed with planning the phase 2 study, where we hope to be able to provide this treatment to more patients who potentially could benefit. Next slide. In addition to looking at the blood counts in these patients, we also started to look at other signs of efficacy, even though, again, this was a phase 1 study intended to look primarily at safety. In both patients, at various time points, we have seen signs of engraftment as indicated by vector copy number that was otherwise not present. And in both patients, we've also, at different time points, seen signs of MMC resistance in their bone marrow cells. In particular, at the 6-month time point for the first patient, we were able to see pretty significant MMC resistance in her sample, which is shown here. Unfortunately, for the second patient, we were not able to obtain sufficient cells at the time of analysis to be able to do this study. Next slide. And so in conclusion, from our phase 1 study that again was started last year, we have confirmed the early safety of this treatment in these patients. Overall, there were no serious adverse events related to the gene therapy product, including no concerning bone marrow changes in either patient post-treatment. And again, similar to as Juan and Jonathan explained, we do follow-up bone marrows approximately every 6 months for these patients. And again, there were no concerning changes noted on any of those. Additionally, we noted that this type of treatment was pretty straightforward, especially compared to standard allogeneic transplants, and only required a very brief inpatient hospitalization. Patients were only hospitalized for about a week and a half, and again, they received no medications other than the mobilization medications and the cells themselves. There was no immune suppression and no chemotherapy associated with this treatment. Next slide. Again, because this was a phase 1 study, we've been primarily focusing on safety, although early efficacy was also looked at. At 6 months, as I indicated, both patients were clinically stable, showing engraftment of the gene-marked stem cells, which allowed us to then proceed to the phase 2 study. And at 12 months now, we've been doing further assessment of these patients. The first patient has stable blood counts comparable to pretreatment, and the second patient, unfortunately, has had to have several red blood cell transfusions after she had a pretty severe influenza B infection that caused count suppression. We're still in the process of doing further assessment of these patients, and in particular, doing the research studies to be able to look at the specifics of their samples more carefully. But unfortunately, the COVID-19 situation has made that a bit more challenging. We're hoping to follow these patients further to continue to monitor their safety and efficacy as we continue to advance this treatment for other patients. Next slide. And so with that, we're in the process of, again, opening up this phase 2 study here at Stanford Children's. And I believe there will be another site in Minnesota where we hope to treat a total of 5 additional patients to continue to assess for safety and really start to look at efficacy of this treatment, where we're hoping to see similar results, if not even better, to what our Spanish colleagues had seen. Again, this is a worldwide study where we're combining our efforts together with our colleagues in Spain, and I believe there will be an additional European site in London as well. Next slide. So as I mentioned, we had this phase 1 study that was opened at the beginning of 2019, and we have now opened a phase 2 study here at Stanford Children's earlier this year. We were hoping to initially treat patients at the beginning of the year, but again, due to the COVID-19 situation, we put things on hold temporarily while we assess the situation around us, and have now lifted those restrictions and have started screening and enrolling patients for this study. Again, this is a study that's very similar to the previous study that is being sponsored by Rocket Pharma. We've really made no changes to this phase 2 study, apart that now patients are not required to have any decreased counts prior to enrolling. Next slide. And so with that, I'd just like to thank all of my colleagues here at Stanford, as well as our collaborators and supporters and friends at Rocket and at CIEMAT and the rest of the colleagues in Spain, as well as our colleagues at the University of Minnesota that have been helping with some of the sample analysis. In particular, I'd like to call out my colleagues, Dr. Rajni Agarwal and Dr. Maria Grazia Roncarolo, who are 2 of the co-PIs on the study and have been helping in detail take care of these patients in plan. So with that, I will stop.
Okay, thank you everybody for such an interesting conversation. We do have some questions up. So our first question is, can mosaicism happen spontaneously at any age, and how is it diagnosed?
And that's a very important question. I think that it probably can, and the group in Barcelona, Jordi Sarias and some of his colleagues have probably characterized this more effectively than anyone else. In fact, all of us are collaborating with them on a review of a lot of their information with a paper that will be coming out. It does appear that it can occur at any age. There have been reports where mosaicism has occurred very likely in a fetus prior to birth, as well as patients in a more advanced age. Likely the incidence of this is going to be less common as people get older, but that's based more on speculation and extrapolation than anything else. But it is the number of cases where mosaicism has occurred and resulted in long-term stabilization or normalization of blood counts, at least as we've seen reported in the literature, is probably several dozen. And it's diagnosed both by following the blood counts, looking at some of these chromosomal fragility assays, and most importantly, at times by even looking at the bone marrow and seeing if the cells in the marrow are becoming more resistant over time. One thing that we've seen in some of the literature, especially some of the patients that the Spanish group's been able to follow, is that sometimes those patients will have correction of blood counts that takes 2, 3, even up to 6 years before it really becomes apparent.
Okay, thank you. Our next question is wondering, why is subtype A the only one that can be utilized for this study right now?
That's okay. Well, go ahead, Juan.
Well, obviously, we must start with some complementation group. It's impossible to start with more than one. And because it is the most frequent, we decided to start with A. But nowadays, in collaboration with colleagues from Rocket Pharma, we are planning to continue with other complementation groups.
And because the different patients with different complementation groups are missing different genes, it needs to be a separate gene therapy product for each of those.
Okay, the next question, if this therapy makes DNA in blood cells less susceptible to breakage, does that also apply to cells that form solid tumors? And what would it take to apply this therapy to prevention if, say, for head and neck cancers?
That's a really important question, and it's something we have thought about a bit. Certainly, there are likely head and neck epithelial stem cells that could be targeted with a gene therapy. Although the hard part there is the kind of therapy that usually works against a head and neck stem cell is a different kind of gene therapy, an adeno-associated virus that doesn't integrate into DNA, and therefore when that cell divides, not only one of its daughter cells gets the corrected gene. But I think that this is an area where certainly there are techniques and basic science work being done that would hopefully at some point allow us to develop that type of therapy to say, hopefully to get a very high percentage of cells in the upper aerodigestive tract with a corrected gene. Right now, that's still something that requires a number of questions and technologies to be advanced that aren't yet the sort of things that anyone's going to be able to put into a patient setting. But it's something that we should certainly work towards for the future.
Yeah, may I simply add something in this respect? Talking about head and neck cancer, which is a completely different field, the first question is that in contrast to allogenic bone marrow transplantation, which is associated with an increased risk of developing head and neck cancer, either because of chemotherapy or because of graft versus host disease. In gene therapy, because we are talking about autologous stem cells and because we are not using chemotherapy, certainly we do not expect a rise in the incidence of head and neck. And hopefully, if the immunocompetence of these patients is improved, might be a decrease, but this is not the primary objective of the trial. And secondly, talking about head and neck and gene therapy, perhaps nowadays the most straightforward approach for fighting against head and neck cancer is the development of CAR T cells. So immunotherapy using genetically modified T cells.
Thank you. Our next question is regarding the number of CD34 stem cells before the therapy. It seems that patient 07 had just 48,600 of these cells. Why do you believe the results were not good, despite the fact that these stem cells became more resistant to DNA breaks?
Yeah. Well, they are certainly more resistant, but levels of resistance as compared to other patients are not that significant in several time points of the follow-up. So based on these results and in general, because of the correlations that we can establish between levels of gene correction and changes in the function of bone marrow and peripheral blood T cells, we still think, and in fact we think, that the proportion of gene-corrected cells is critical to correct the function of bone marrow and peripheral blood T cells.
I think it's also important to emphasize that the initial trial in Spain, there were times particularly that patient who was received a very limited number of cells. In the programs going forward, the goal is that almost every patient would receive an amount of cells that that would enable a greater likelihood of correction or stabilization. And a number of different pieces of the trial, both in terms of the eligibility criteria, as well as the criteria for handling the cells and for putting the cells back into a patient, are a bit more stringent, so that we think that we'll have a better probability of being able to infuse a more meaningful number of cells in a more consistent manner.
Okay, thank you. We have another question on CD34 cells, asking, is there a way of increasing the number of these cells in order to make someone eligible for these trials?
Not to our knowledge, but one of the avenues of research that many of us continue to pursue, both in other transplant settings and specifically for Fanconi anemia, is the possibility of collecting CD34 cells from a patient and expanding them outside of the body, ex vivo, in a way that still allows them to be stem cells, but for there to be more of them. This is not part of the current study, but it certainly is something we're looking at in laboratory settings, and it's certainly something that would conceivably become part of a future clinical study if the results are promising and they look like they're working specifically in a Fanconi anemia group of stem cells. So it's a very important question, and it is something that a number of people, including people on our teams, are really looking into for the future.
And this is why we're such advocates for early screening and early diagnosis of Fanconi anemia, so that patients can find out as early as possible, hopefully way before they have bone marrow failure, or when they have a lot of CD34 cells still in their bone marrow, so that those can be taken out, fixed, and given back. There are also several clinical trials looking at small molecules that potentially could try to save or maybe even increase those CD34 cells, such as quercetin, metformin, or L-trombopag that are offered at other centers. But so far I haven't seen significant data that shows increase.
There are clinical trials that have already done these type of approaches when cord blood samples, also having very low numbers of stem cells, were used for transplantation. Nevertheless, this is a very different material. A cord blood from a healthy donor is very different from bone marrow from a Fanconi patient. So as Jonathan mentioned, careful studies in preclinical work should be done before entering in a clinical phase.
Okay, thank you all for that. We have Kirpa who would like to ask a question from our viewers. Kirpa, are you there? Kirpa, I think you might be muted.
Hi, sorry. I'm just trying to juggle my kids and listen, so I might have missed what you said.
It looked like you had your hand raised to ask a question. Would you like to ask a question?
Oh, I'm so sorry. I think I might have done that by accident.
Okay.
But I did have a question, which I'm not sure if hopefully I didn't miss it. But it was about that we've been waiting for the gene therapy trial in the UK. and we've been waiting for a few months now, and it's kept getting delayed. Do we have any more progress on when it's actually going to start in the UK?
Yes, it is definitely appears that we'll be enrolling patients within the coming 2 months or so, potentially sooner. There have been a number of issues that have had to be resolved, but it does appear as though Dr. Booth and Thrasher and Ancliffe will be able to enroll in the UK. I know that they have been in touch with a number of patients, and a number of patients who, probably more patients than there are slots in which to enroll. And that's been a very important question that we've had to address, is how come only 5 patients in Europe and only 5 patients in the US? We've also gotten questions, why not fewer? And these are very difficult questions. I think that the real answer here is that this is, although we have some promising early results, is still an investigational therapy. And we want to make sure that we're enrolling a modest number of patients until there's more evidence that this is providing, that it's not only safe, but it's also providing a benefit. And the number of patients to be enrolled in both continents is something that was agreed upon with health authorities and hospital committees as a means of really giving us an opportunity to appropriately test how well this can help Fanconi A patients, while not exposing an inordinate number of people to a therapy for which we have not yet demonstrated conclusive benefits. So it is very much a balancing act. One of the questions that we've received is, what happens if my child, or if I don't get a slot in one of the available slots that's being happened? What will I eventually be able to? And I think our plans are that if there is compelling evidence that the therapies are benefiting a reasonable percentage of patients and continue to appear safe, we will create mechanisms within the coming 1 to 2 years, conceivably, that would enable either expanded access, if there's evidence that the therapy is working or potentially or not working well, or only working in a very small percentage. There will be additional studies potentially looking at cell expansion or the use of very targeted non-toxic antibodies to help condition the marrow. So this is not the only gene therapy effort that will be happening going forward, but it is much as we're going to be able to do in the coming year, but hopefully there will be more opportunities. I know we're already past the hour. I just wanted to call your attention to the fact that we did recognize that likely there's a lot of questions, and almost all of them are really important and excellent questions. In fact, all of them are. And we do have a number of mechanisms to try to address the questions that we don't have time for today. And that includes a FARF sponsored meeting that's on the screen now next week on July 7th. We'll also have additional venues for questions on the Rocket website, both via our patient portal, as well as a patient-focused email address. And we want to make sure that however you're comfortable providing a question, we're going to have a mechanism to address that, whether it's in this follow-on session, an email, or some of the other portals that are part of the website, because the Fanconi anemia is complicated. gene therapy in Fanconi anemia is complicated, and your questions are really important. And if it, we'll come back a second and a third time to try to make sure that we provide some satisfactory answers to the best of our ability.
And the clinical teams at each of the sites are also available to answer any questions. So feel free to email me at any point in time, and I'm happy to discuss the treatment as well.